Hello, good morning. I'm Dr. Venkatesh. I'm from Toowoomba. College has asked me to present on this topic. When the college asked me to present on this topic, initially I thought that all of you are the first year registrars who has minimal uh, experience in psychiatry, so I should start with a very basic issues. But later I realized that most of you are at least 25 years old, and some of you could be older than me. So you have lived life experience, and that's a huge contribution. And then, to reach a position of registrar, you have gone through a decade of medical training, and through in that course, you have become kind of teachers to a lot of your junior people, and I have seen a lot of people now registrar teaching RMO. So I had to train the trainers, so it's a bit more complicated. Obviously, we're all the doctors. That comes with a kind of a assumption that you belong to some kind of aristocratic family, and people below you look forward to you, and the people above you kind of look upon you for the decision and the guidance. So, in that context, I wanted to see this presentation more as a humanistic presentation where we look at depression from as many perspectives as possible so that we could develop a holistic perspective on this depressive illness. And this is quite important in recent time because we have to give away all our health record to our patients. They can see what we think, and there is a huge movement towards recovery, patient-centered, value-centered care, and even the finances are gradually going to the hands of the patient. So, and outside the clinic, the doctor and the patient are one and the same. They are same kind of human beings. A lot of doctors also suffer from depression, and maybe you have to deal with one of your colleague who went to the same college as you are, primary school as you are, and now suffering from depression. So, with that in mind, I would start. Uh, we should first look at the emotions. Uh, as Charles Darwin saw it, he saw that emotions are kind of a intuitive skills which helps organism to make a accurate and quick assessment of an environment, and it helps in their survival. If it is a painful, a dangerous environment, the animal withdraws, and if it's a nice environment, they approach looking for nourishment. That's the basic concept of emotion. That's what it serves. He also did a lot of work understanding the emotion and published another book, Expression of Emotions in Man and Animal. And it's, uh, of course, he could recognize the more variety of emotions, which not just pain and pleasure. And this work was further carried on over the last 100 years by a variety of anthropologists, ethnologists, and they have subdivided emotions in uh, many, many ways. And we today will focus on sadness. And with clear knowledge of all these things, we are assuming that sadness is just a single emotion. Now, from a clinical perspective, emotions could either be seen as two different aspects. One is what is subjectively internally experienced, kind of feelings, mood, emotions, and what is seen from outside, the objectively observable in terms of our facial expression, the speech, way we dress, our attitude, all those things reflect our emotions. That's called as affect. And there's no one-to-one relationship between these two aspects in the sense that emotion is equal to the uh, outward effect. There's a lot of barriers the people have to go through in terms of the social situation, the cultural upbringing that they have, and so I can go on the list like secondary gains, whether ego or pride, the kind of social image that we have to maintain, or the inherent neurological uh, abilities the people may have, like people with stroke, not just stroke, in terms of autism or Parkinson, all those kind of things. And also people are very good in having one emotion and showing up a very different kind of emotion, which the masters of them could be psychopathy. And also all of us both can experience and also express emotions uh, to a different extent. Nor some of us have a very narrow range of emotions, some of us have a quite broad range of emotions, and some of us have can easily express one emotion but can't express another emotion. Like I myself kind of find it hard to express happiness or appreciation that easily compared to others of my colleague. And again, that factor is different in. Now, coming to the emotions per se, uh, there is another quality to this emotion. The one aspect of it I would consider is mood. Uh, that is, uh, like the emotions or the mood. Let's say mood. Uh, Here, the mood is seen as a kind of a pervasive emotional experience, which colors whole human experience. That's an important. Here, the role of emotion changes not as just a reaction to the stimulant, but also the emotion coloring how person sees the environment. This is bidirectional interaction. Now, we will jump on to another dimension. When there is a stimuli, we also start seeing that there is an emotional reaction which comes after a bit of time. Some of them can come immediately, some of them come latency, and some of a different intensity and duration. So again, we can classify any emotional reaction in a different dimension. Some people can react quickly, some people can react for a long period of time. Emotions also manifest in a different uh, way in at different ages. So is depression. Depression as an illness. I'm indulging you in all those things. Uh, so, but so when we see a person, so we have to take into all this consideration that I have talked about. Those are the fundamental aspects of any kind of emotion. It's nothing related to any psychiatric illness. That's the way. So we are given a situation like this, as it is depicted in this diamond box, and say what emotion it is and what this condition is. And coming to our clinical practice, we have limited time. We have limited time, and we have to make a diagnosis quickly. However faulty it is, we have to make a diagnosis quickly. And in this domain, we would say that we need some kind of a diagnostic tool to differentiate from one thing from another. In clinical aspect, what is normal sadness? We need to be distinguished from sadness secondary to illness. So there is, in a true sense, there is not much difference. It is only kind of a line in the sand that we have drawn, and it is going to be faulty. There is no apologies for that. Now, briefly, before jumping on to the depression, we'll just look into the general criteria that we use. To make a diagnosis of psychiatric illness, we use a cluster of symptoms. Those symptoms are intense enough to cause dysfunction, and they are persistent enough for some length of time, and they could be excluded. Other causes could be excluded. In depression particularly, this exclusion criteria is quite a tricky one. How can we exclude somebody's sadness as more than what is normal for a given situation? When we consider entirety of the human being, it's hard to say that one person's emotional reaction that we are seeing is ununderstandable. It is hard. So that's going to be tricky. So now, just having understood all these philosophical uh, debates, we'll come to the diagnostic criteria of depression. Well, I'm using ICD-10. Uh, Quite similar. ICD and DSM are almost quite similar, and you could use both in the exam. They won't penalize you if you don't know DSM-5. They won't. So it classifies as major symptoms and minor symptoms, and major symptoms are three of them. Those are pervasive sadness, inability to uh, enjoy life, and significant level of tiredness or psychomotor retardation, both subjective and objective. At least two of them should be present to consider diagnosis. In the first criteria, it is not the sadness per se that is more important. Pervasiveness is more important. That the sadness is there whole day, every day for 2 weeks in a row, accompanied by all the other symptoms. And then there are a set of minor symptoms. So you can again classify into cognitive and also physical. Okay. In terms of cognitive, you can say lack of concentration, low self-esteem, guilt, negative view of future, and behavioral or thoughts, in terms of self-harm or suicide, and disturbance in appetite, disturbance in sleep. Of course, two of them is enough. And depending upon how many minor criteria are there, then you can classify mild, moderate, severe, and so forth. And in ICD, again, it goes a bit deeper than that. To say that this comes from a concept called as reactive depression and endogenous depression. Reactive depression, in a way, is considered as a kind of a depression which is understandable in a real life, and endogenous depression is seen as a which is difficult to understand, and it's considered a biological depression. There are 8 criteria. They're quite simple to remember. You know, you can link. It is one of the criteria is kind of sadness. The sadness here is there is a diurnal variation. That's one important, and they're particularly sad early in the morning. That's one of the characteristic feature. And then the lack of anhedonia is quite profound. They say that not only that they can't enjoy day-to-day activities, but also they stop enjoying what they used to enjoy things. And also the people from outside can see that there's not much emotional reaction. It's quite painful when we say that people with depression, when a child comes to them and they can't show emotional reactivity, they can't be bothered, and that awareness itself is quite painful. And sometimes they say that, if I could cry, I would feel better. Even the that's the sense of numbness is also is considered in this domain. Another is sexual libido. Psychomotor retardation here, uh, the objectively people can see that they are quite slow, like it's almost like a Parkinsonian. So there is a variety of sleep, that is terminal insomnia, where people wake up quite early and they can't go back to bed, or they are interrupted sleep, they can't go back to bed. And weight loss, huge issue. Exactly in the opposite direction. Exactly in the opposite direction, from a somatic to atypical depression. I would say, from an Australian experience, you can say that this is quite common in the borderline. Their mood is reactive. That's the one of the profound. So if something good happens, they are reactive, and at the same time, they are intensely mm, uh, react to negative event, especially interpersonal rejection. That the prickly nature is the characteristic. And apart from that, they also say that their whole body appears like frozen. They are made of lead. They lie down in the bed without any uh, ability to move. And they also sleep a lot. They don't just spend time in bed, but they sleep. And they eat a lot, obviously, gain weight. This is from the college guidelines, so there are a variety of way you can classify. Uh, I'm sure you could read about all those things. And from a longitudinal perspective, uh, depressive disorders could be again subclassified into major depression, persistent depressive disorders, which is old term for dysthymia, where uh, depressive symptoms would does not qualify for a major syndrome, but they are subsyndromal symptoms, but they persist for nearly 2 years. They do disturb their quality of life. They somehow drag along themselves. Disruptive mood dysregulation disorder is a new concept that's been introduced in DSM-5, which is more akin to atypical depression, or it's more seen in adolescent population, with angry outbursts as one of the predominant things. Now, coming to the lifetime prevalence, nearly 4% of the general population across the world suffer from some form of clinical depression uh, in any given year. And if you consider whole lifespan, you can say 15% of us have gone through at least one episode of clinical depression, diagnosed, undiagnosed, untreated, all included. That's significantly more compared to its counterparts like bipolar disorders or psychosis. And illness characteristic, depression, we can consider it as a illness of a younger population. Contrary to the normal belief, the older population are not the prevalence of depression is not that common. And they say mean age of diagnosis, uh, mean age of onset would be around 27 years of age. And it is a kind of a chronic illness. It doesn't respond to treatment that well, even though we would love to believe that, uh, only 50% people completely get better by end of 6 months, and it would take nearly a year for 70% of the people, and 20% of people, nearly 15% of them, would be still left with some kind of a depressive symptomatology. Now, coming to the comorbidities or differential diagnosis, I don't know how to differentiate these two when would you say something is a comorbid, when would you say something is a differential diagnosis? We don't know. We'll not go into the philosophical debate. We can say that depression is comorbid with all the psychiatric illness, starting from vascular dementia, vascular depression in elderly, to addiction, where addiction specialist feels that it is secondary, addiction is secondary to the primary emotional problem, or bipolar illness. Anxiety could be almost 50, the high comorbidity. Some people consider somatoform disorder as a masked depression, where they present with a whole range of bodily complaint, and they have inherent difficulty in expressing their emotion, talk in terms of emotional terms. So similarly, depression is equally comorbid with physical illnesses, starting from nervous system to the cardiac system to whole range of conditions. Depression is also equally, as a doctors, we kind of tend to forget this aspect. Okay, lot of psychosocial adversities also causes depression, like discrimination based on gender, race, practical difficulty in terms of homelessness, poverty, being having to fight with Centrelink, or relationship difficulties within the family environment, uh, religious issues, all those things. This kind of inherently poses a significant challenge in terms of when would you call something as a comorbid, and when would you consider something as a etiological fact. With that in mind, we'll go into etiology. We will first look into the biological parameters which are linked. If you look into the history of humanity for the last 1,000 to 2,000 years, we uh, started thinking that emotions are depression is related to heart, broken heart is related to the depression, and last few centuries we are thinking that brain is the center of mind, so depression is related to brain, and gradually we realized that a part of the right brain is more related to the emotions, and the tumors and the strokes which are affecting that part of the brain has more tendency to manifest in terms of emotional disturbances. And within the brain surface, we kind of narrowed zoom to a frontal lobe as one of the main area where emotion control come into play, and disturbance in that circuit is related to the thing. And then we gradually move to, no, it's not just the surface of the brain, it is the emotions. So the depressive illness is related to the subcortical, or the primitive aspect of the brain, animal aspect of a brain, limbic system, and other whole range of diencephalic structures are related to depression. And then we have come to the conclusion that everything is connected to one another. It is not the single brain region that's important, it is the networking of those variety of brain regions that is important. And we also have studied a lot of endocrine system. In clinical practice you can see that anyone who comes with psychiatric diagnosis, we kind of look into thyroid and make a diagnosis, or there is subclinical and there is a depression. Linkage is not that great, but we still do that. Another one of the most important thing we have to take from this here, HPA axis, hypothalamo pituitary adrenal axis. It is a kind of an axis which is related to stress response. When there is any kind of emotional stress or any environmental stress, the brain hypothalamus sends out a signal to its endocrine system to release more hormones, and hormones go down and steroids are released, and steroids changes the body configuration to fight the stress. But once steroids are of certain level in the brain, they send a negative feedback to the brain, say things are okay, stop releasing CRP. In dexamethasone, uh, this negative feedback is faulty in people with depression. It's not one-to-one relationship, but it's more common than normal population, and it is more disturbed uh, in psychotic or endogenous depression more commonly than general population. But we have to take it with a pinch of salt that this negative feedback loop doesn't work as we get older. So the elderly population have much more false positive DST, dexamethasone suppression test. Okay, for centuries we have been preoccupied from ancient time with some kind of a fundamental aspect. We thousands of years ago we used to call them as humors, and now we call it as neurotransmitters. We associate monoamines like serotonin and norepinephrine, epinephrine as one of the fundamental reasons for depression. To put it in much more crude and simple manner, monoamine hypothesis of depression, which is the most successful form of biological theory, states that at synaptic level these neurotransmitter levels are less, or they are not effective because the receptor is not functioning well. And so the depression, when we increase the level of those neurotransmitters by a variety of chemicals, which can increase by either releasing more chemicals or blocking the uptake receptors, depression improves. It's still a debatable why, when you give an antidepressant, serotonin level increases in synaptic level much quickly than a clinical improvement of depression that we see. And also, we are not sure which came first, whether it is low serotonin which came first and then depression, or it is the depression which came first and serotonin is just one manifestation of it. And sometimes it can also be other ways. Yes, increasing serotonin helps in improving depression. It doesn't automatically prove that uh, they're related. It's like people who are anxious drink alcohol. It doesn't mean that they have alcohol deficiency syndrome. So there is a lot of debate about this. I would not go into all the receptors, serotonin receptors, uh, norepinephrine receptors, and post receptor intercellular communication channels and their abnormalities and so forth. But uh, we need to know that we have been trying to link uh, genes to depression, or depression to genes. And in this effort, however faulty it is, okay, these are the three common three things that's been recently suggested, not no, sure, is some chromosomal regions, which is more common in bipolar disorder, but not so much in recurrent depression. I would skip this so that we can talk about this later. And ECT is the most common form of depression treatment and most effective form of treatment that we have. And it is effective especially in kind of severe depression with psychosis. So in that sense, studying the mechanism of ECT would give clue to the uh, etiology of depression. Per se, we have variety of theories about how ECT works, but again, we don't know absolutely how and why it works. Now, coming to the psychological theories, uh, studying psychology of depression is almost, we can say, uh, whole field of psychology. Uh, yeah, if we have to talk about Sigmund Freud, he's a neurologist. He started the field of psychoanalysis. He felt all human behaviors are secondary to biological drive, and when those drives are not allowed to express themselves for a variety of reasons, that pent up, unexpressed uh, feelings lead to depression. And he also felt that childhood plays a huge role in uh, psychology of human being, and so any loss or any abuse during childhood leaves an indelible mark on human psyche and leave them vulnerable for depression in the future when they lose something that comes back. And he also brought in the issue of meaning, and that meaning could be unconscious, and it generally goes back to their early part of life, and understanding them is important. Another theory he proposed is depression is in a way is an anger turned inwards. And so to explain it, as a child, if something bad happens, somebody abuses them, somebody neglects them, they have a general tendency to think that it is the child's one's own fault, and parents are all right. Parents are right in doing what they did because the child did bad. That's the way, and that mode of thinking persists even in adulthood. And when something bad happens, instead of expressing anger towards parents, as a child, if it expresses anger towards parents, it would be beaten up again. So it would be much more fruitful to have anger towards oneself, which helps in their survival. But in adulthood, it doesn't. So in that sense, he thought that depression is kind of anger turned inwards. His theories were taken forward and modified and elaborated further. Melanie Klein is one of them. She saw anger not as a uh, secondary to frustration, and she saw anger as an inherent aspect of all of us. Um, as the outside world is full of good and bad simultaneously, all of us have good and bad things in ourselves. We also, emotion always comes with love and hate. They're not separate, they're one and the same, they're different faces of the same coin. And our a mature person will have integration of it, and the person who is not matured has a tendency to split. And all of us can say that we can integrate, but we also split. That's and all of us oscillate between uh, two positions. She calls as paranoid schizoid position, where we think the outside world is bad and we are right, we are victimized. And another is we are bad, we have destroyed the other. We oscillate between that. So she saw depression as realization that due to our anger, we damaged the most loud object, and in a way we caused the destruction. And this insight is the reason for depression. Further, Edward Beibring is one of the psychoanalysts, and he considered that we all of us have ideal image of ourselves as very good human beings, uh, but in the real we are just mediocre. But if the difference between these two is too huge, then depression sets Another Italian psychiatrist felt that people with depression live for dominant others. They don't know how to live for themselves. To give an example, uh, they can live for a church, live for an organization, live for a value. But when there is a stress, when there is an event like I've been working for Toowoomba, and if the Toowoomba hospital rejects me, and I feel quite invalidated. I have dedicated all this life, or I've been working as a psychiatrist and college doesn't support me. In that sense, we kind of our at a deeper level we start questioning the what is the value of life. That John Baldwin is one of the profound, and his theories have influenced many theories to forward. To put it simply, all of us, like any other animal group, have tendency to attach to parental figures. That's how social life is built. And when there is a disturbance in other childhood attachment, we carry that vulnerability all through our life. That leads to working model that we have. And when we go through losses in the adult life, they bring back all the unaddressed pains, unaddressed grief, unresolved grief of childhood, and they manifest in what we call as depression. In reaction to this psychodynamic thinking, around the same era, early part of 20th century, there's another group, behavioral uh, psychologists. They saw it's futile to think about the subjective, immeasurable things. We should look at objectively measurable things, that is, the behaviors. And that's how we should, otherwise, we can't make scientific progress. They felt that depression, like any other human behavior, is a learned behavior, learned over the whole lifespan. It is built with a lot of reinforcement, positives and negatives, and a lot of social remodeling, and so forth. And so, changing those things, conditions, and providing a good role model is the way to move forward. This hypothesis is particularly useful in some aspects of depression, in the sense of how being inactive, being isolated, okay, increases the chances of being in a boring environment, and reduces the uh, enjoyable active opportunity to see enjoyable activity, and that kind of forms a vicious cycle. Again, in reaction to behavioral theory, where they said that all subjective things is out of question for us, it's not scientific. Uh, this two dominant psychologist and psychiatrist felt that we have ignored the role of thinking in our emotional life, and they drew heavily from ancient Greeks, uh, Socrates, Stoics, and Epicureans. Mm, it is also is the most successful form of its psychological therapies in the last decade, and it has expanded, and it has drawn a lot of concepts from other fields of psychology, um, including the Eastern philosophy of acceptance. That's important. Like initially, when CBT started, it started with a change as the major concept, and later they went, instead of looking for change, if we look for acceptance, the change would come in. That's the paradox of it. So, to make it simple again, uh, when there is a trigger, it is not what happens that really matters. It is how a person interpret that event that's important in causing depression, and those interpretation manifest in their automatic thoughts, their attitude, their value system, and which pervades how they see the world, how they see themselves in general, how they see their future. And those people show lot of rigid thinking, uh, immediate conclusion, quite a generalized context. It will always be like this, or it should be like this, those kind of things. And normally they have a lot of compensatory behaviors, like, if I think that I'm not a good person, I'm not good enough, I became very perfectionist and everything has to be like this. That's in a way compensating our uh, uh, inner self-worth. It goes on for a while. It is helpful in so many ways. But when something bad happens, you don't have to be bad. Like, a perfectionistic mother has a child, a woman has a child, and go through perinatal period, and they want to do everything perfectly, and it's not possible to raise a child perfectly. That imperfection and the longer term view of cognitive therapy, where they look into the attitude, not just automatic thoughts, the attitude, is schema therapy, which looks into how our attitude comes uh, to existence all through our life, both past life experience and current, and work towards modifying them. Around the same time when CBT came to existence, there is another equally uh, profound psychological therapies came into existence. They draw inspiration from existential thinkers, and it drew out of Nazi camps. Uh, Viktor Frankl, he's a psychiatrist who survived uh, Holocaust, and they saw no, all the things quite similar to CBT, but they saw that we need to fundamentally examine our attitude towards existence, and ultimate acceptance of that is the cure. And they see life as oscillating. We are all going to die, and with the knowledge that we are going to die, we have to embrace life, and only with the knowledge of death we can appreciate the value of life. And we are all free, we are condemned to be free. The painful aspect is we are responsible for the choices that we have made. As a human being, we are social animals. We want to live with people. We want to belong to a family. We want to be a part of a church. But fundamentally, our experiences are our own, private. No one can share us. They can empathize with us. They can imagine, but we are alone. We have to walk our own life. We have to walk our own path. As a human being, we are hardwired to find meaning, but this world is just meaningless. And when when there's a stress, this uh, we have to come to terms with this. Other much more softer way of looking at psychology also came into existence for the last 30-40 years, and one of it is interpersonal psychotherapy. They initially started off with mm, psychoanalytic theories, but they, instead of focusing too heavily on childhood, they, even though they drew things from the childhood and psychoanalytic theories and attachment theories, they looked into here and now, in the sense that depression is seen as a understandable reaction, or as a comorbid to interpersonal conflicts, interpersonal deficits, or anything that's happening in the relationship. So relationships and emotions are interlinked, and helping person to have a meaningful relationship helps them to conquer their depression. Much more softer and positivistic approach is humanistic theories, who saw that all of us humans have needs, and those needs comes in variety of layers. When those needs are not met, uh, depression sets in. So the treatment of depression should look at how to help the person to acquire those basic needs. Some of the basic needs we may need to do practical uh, support, and that itself would be enough. And some of the higher level of human needs a whole load of psychological intervention. And Carl Roger is quite famous, and he felt, and these theories are very very important in the history taking itself, showing an unconditional positive regard, being open, genuine, true to ourselves when we are interacting with them, not just faking it, and being empathetic, true suffering of a human being. That itself has a transformative influence on the human being. And he also says, um, when we show unconditional positive regard for the person and accept who they are as they really are without demanding them to change, that curiously changes them. Again, here the more for the last 20 years or so, I would say 20, 30 years, I would say postmodern thinking has influenced psychiatry whole, and so is the depression, treatment of depression. And here we see narrative therapy, recovery oriented nothing. All those things look into uh, way we talk about ourselves, the stories that we tell, the language that we use, the power dynamics, that is the values that we have, our live, respecting the lived experience and so forth. Those concepts are applied. So I've not truly understood all those things mm, very well, so I would just leave it here for the time. So, when we understand all these things, both biological and psychological and social theories around depression, it's quite easy to formulate. Uh, the college proposes that we probably should use a formulation in this model, and it's important that we write up a formulation because all our health records are going to be owned by patients, and so they have a ready access to that. So it's important our written formulations are seen as a psychoeducation material. Coming to the treatment, our formulation uh, should influence our treatment. That's how naturally happens. And in the recent version, the college has proposed this way of conceptualizing the treatment in terms of where they say that they're slightly like if you looked into the concept itself, if you even they pay heavy emphasis for biological treatment in a psychotic, bipolar, or melancholic depression. But as we move down the scale, even to part of melancholic depression, reactive depression, it's more of a psychosocial interventions, and they there is a huge emphasis on lifestyle factors, which is in keeping with the recovery model. Now, just we'll look into the lifestyle factors. Uh, to start, instead of doing something, if we can encourage people to give up some things like smoking, alcohol, that itself has a profound effect. And the college document says that uh, just not smoking, quitting smoking, uh, stopping using drugs itself has a as powerful effect as antidepressants. And next line of treatment is more of a behavioralistic approach in terms of mm, sleep, excess physical activity, and uh, eating habits, those changing them, on whole range of psychological treatment as we talked about, and overall treatment, and then later we can come to the antidepressant. Overall treatment uh, is conceptualized like this: response, remission, recovery, and looking into looking into the treatment per se. As I earlier pointed out, the treatment is not miraculously uh, better, and it is a slow process. And it's important that we give this information. Working in a public sector, I kind of see pressure from the both the side. The patient want to get better quickly. Give me medication which can fix this. That's one aspect of it. And our administrators have whole range who demand get them out quickly. And most of the patients that I look after come from a very premorbid, low level of premorbid functioning. So I generally look after people who are poorly responsive to the treatment. Initially, when we started the treatment, when we conceptualized, initially when we started the treatment, when I came to psychiatric field, I was of the opinion that over time we will be able to help people to completely remit from all their illnesses, but that youthful enthusiasm has disappeared, and I'm of the view that with our treatment, some people improve, some people don't. And when people do improve, and some of that improvement is just a natural process itself, we don't have to do anything. We are fortunate enough to be there. That's it. And in some aspect, in other aspect, is major domain is just the fact that we are there. We are doing something, whether it was good or bad. We're there and we are doing something, that itself mm, as a positive influence. And there is a very small room for the specific effect, the specific antidepressant that I chose, a specific DBT therapy that I used, a specific psychoanalytic interpretation that I gave. All those are very small effect. Thank you for your patience.